So an algorithmic approach to hyponatremia, a very important topic. All of us, let us focus. So all of you know this I have shown you in the water metabolism. Why we require to know about a little bit of water metabolism is because hyponatremia is of course connected to water metabolism. Hyponatremia doesn't occur on its own. There will be disturbance in the water also. So there is 35 liters of body water is total body water of around 60-65 kilogram body weight. 55% of the body weight in the male and 50% in the female. Slightly less because of the adipose tissue in the females. So if you are weighing 70 kilos, 55% of the weight is body water, and that is distributed into extracellular and intracellular, that is within the cells 40%, that is the intracellular cytosolic water, and then the extracellular water, which is just outside the cells, means it can be either in the interstitium or it can be in the plasma. It can be in the intravascular. Intravascular, we have 5 liters of blood. The liquid part of it is 2.5 liters. So interstitial fluid is the remaining component. You can see the major component of water is in the interstitium and of course in the cells. The little bit of water that is there in the intravascular compartment is being very well balanced between the interstitium and then the cytoplasm and the plasma. Total body water, 55% of body weight in male, 50% in female. Fat holds less water. That is the reason obese people also, the water content will be less. They can easily get dehydrated. So obese people, okay? Remember that. So total body water distribution, 70 kilogram person, 60% of that is water, 60% is 28 plus 10.5 plus 3.5, which is 14 plus 28 is equal to 42 liters of 70 kilograms is water. 42 liters, as you can see here, 42 liters is the total water of the body. And this is distributed as we have seen in the previous slide. I'm giving you the numbers here. Total body weight, 60%. 42 liters here. And then ICF, intracellular fluid, is 2/3, around 28. And then the total body water and the ECF extracellular fluid is 1/3. And again, interstitial fluid. And the intravascular fluid is around 2.5 liters or whatever it is. Roughly, you know, that is the proportion. The relative distribution of ions you require to know very much. What is that relative distribution of ions between ECF and the ICF? Intracellular fluid ions are slightly different or more or less they're markedly different than the extracellular ions. So extracellular, intracellular ions, you see sodium is the dominant ion and here in the extracellular fluid, whereas that is very small in the intracellular fluid. Potassium is the dominant ion in the intracellular fluid, whereas that is very little, around 4 milliequivalents in the extracellular fluid. Calcium, more or less same. Magnesium also, you know, the intracellular magnesium is more and less in the chloride is very much outside and less in the intracellular fluid. Bicarbonate is rather same. Phosphates very much more in the intracellular compared to the extracellular. So what is the general picture? Sodium, chloride, and then sodium and chloride are the dominant electrolytes in the extracellular fluid. Potassium and then phosphate are the dominant things. Others are more or less equal. So daily water balance, we all know, around 2.4 liters is the water that is approximately taken in a summer day. It could be even more. So what is water consumed as water is 1.5. With the food we take some water, that is vegetables contain water, rice contains water. All that water is 0.5 and there is what is called the biological oxidation water. What is that? Every reaction ends up in water and carbon dioxide. So the catabolism of all the fuels ends up in water and carbon dioxide. That is called the biological water. So in a way, that is the distribution of urine around 1.5, perspiration around 0.4. Loss in the breath, respiratory loss of water is usually not accounted. And that is a significant loss of water through the respiration. And fecal loss may be around 100 ml of water may be lost. unless the person is having diarrhea. So this is roughly the water distribution in input and output. So osmolality, we all know several times we have been calculating, very important measure to know what is the osmolality of a substance like plasma. If you want to know the blood osmolality or serum osmolality, 2 times sodium plus potassium, glucose divided by 18, 1 divided at 2.8. Because glucose and 1 are in the milligrams, we want to convert them into milli-equivalents. Because sodium and potassium are milli-equivalents, if you want to add, then you have to make them the same units. And that results in 132 sodium plus 4 potassium, 2 times that, 2 times 136, 108 divided by 18, glucose by 18 is 6, 14, 1 divided by 2.8 is 5, total is 272 is this product, and the 11 is this, that becomes 283. That's around the plasma osmolality. Around 283 milliosmoles is this one. Effective osmolality, osmolality per milliosmoles per kilogram. So easy to remember, 2 times sodium plus glucose divided by 18, because 1 is more or less constant. Glucose is the one which varies with the food intake and in diabetics very much, and sodium is the dominant ion. Potassium you may not consider in the just rough eyeing of your calculation. If you know the sodium and glucose, you can have a mental picture. What is the osmolality like? By just looking at 2 times sodium plus glucose by 18. So determined by those solutes which do not permeate the cell membrane and act to hold water in the extracellular fluid. That is how the osmolality is restricted. Not all ions are permeable across the cell membrane easily. There is gating of these various ions, and they will be available to be transmitted only when the gates are open. So lipid soluble substances like urea can cross the cell very easily, but then plain urea without lipid solubility cannot cross. And then let us see about the sodium now, because we are interested in hyponatremia. Sodium is a major extracellular fluid cation. The major intracellular fluid cation is potassium. Major extracellular fluid cation is sodium. So 140 milliequivalents per liter ECF versus 25 milliequivalents in the intracellular. That is the difference. 145 versus 25. Obviously, sodium has to go into the cell. Why it has to go into the cell? To depolarize the cell membrane. Every time sodium has to go in, potassium has to come out. And the sodium channels have to be opened for that to occur. That is the action potential. Other than the reason for depolarization, sodium needs to move in to adjust the osmolality of that tissues. So total body sodium is, if you multiply per liter 140 milliequivalents, and how much fluid is there, depending on that, so that will be around 5 liters of 5,000 milliequivalents of sodium is there in the body, and around 90% of that is extracellular. We know that. Responsible for more than 90% of total osmolality of the ECF. If the osmolality, let us say, is 280 or 285, 90% of them is contributed by sodium, because 2 times sodium itself is already 135 into 2 is 270. Osmolality being 280, around 92% is contributed by the sodium. So maintenance of ECF volume and blood pressure are dependent on the sodium. The daily requirement is more than 100 milliequivalents or 6 grams of sodium salt, which is equivalent to 2 grams of sodium. Sodium, 2 grams, that is without the salt, Cl. So that's around the requirement per day is 6 grams of salt per day. So if 30 days, 30 into 60,000, 180 grams of salt only is required. How much we are consuming, you can imagine. All that has to be excreted by the kidney. Okay. Called natrium, that is why the symbol is Na. Natrium is sodium, natrium, that is why the symbol. So the summary of this slide is, it is the major extracellular fluid cation, 100 milliequivalents per liter versus 25 in the intracellular, and 80%, 85 to 90% is extracellular in the sodium, of course, and 90% of osmolality is maintained by the sodium, and then sodium values daily requirement is 6 grams of salt, which is equivalent to 100 milliequivalents. 1 gram is 17.1 and multiplied by 6 is 100 milliequivalents. Roughly 17.1 1 gram gives, so 6 grams of salt gives around 100 milliequivalents. Latin name is a natrium. Okay. The hypothalamic pituitary endocrine axis. This is the one which is governing the fluid movement and the sodium movement, governed mainly by the arginine vasopressin, also called the antidiuretic hormone or the ADH or vasopressin. It is called AVP because the amino acid arginine is there in that arginine vasopressin. That's why it's called vasopressin or AVP, synthesized and secreted by the posterior pituitary or the neurohypophysis. And the nuclei are in the hypothalamus and the terminals of the nuclei are in the pituitary. So in fact, it is being generated from the hypothalamus nuclei, and those nuclei have the terminals in the posterior pituitary and neurohypophysis, where the antidiuretic hormone comes into the posterior pituitary, from thence into the pituitary circulation. There is a beautiful sort of portal circulation there within the pituitary, which harmonizes these hormones into the blood there. So you also should remember this, I have already shown you earlier, if the plasma osmolality is normally 285 milliosmoles and the amount of ADH present is 4 picograms per ml, that is a standard, and if there is a shift in the osmolality towards 275, that means if the plasma is getting dilute, then there requires to be retention of water, so then naturally the ADH secretion will be suppressed, and then there will be no diuresis, and water will be retained and the osmolality will be restored. On the other hand, if there is a concentration of the plasma to 295, we require to retain more water to dilute it, and then so we require more ADH, antidiuretic hormone. So there is no diuresis, water is retained, and then this is brought back to normal. So this is the curve goes, this is a straight line. So where the point A is where there is no secretion of ADH at all, around 280, the ADH secretion becomes 0, and point B where it is around 8 picograms per ml, which is double the normal value. So this is the regulation of ADH based on the plasma osmolality. There are osmosensors in the hypothalamus, and those they decide how much amount of ADH has to be produced. If the plasma is dilute, then no ADH is produced or less ADH. If the plasma is concentrated, more ADH to retain more water. Okay. Now, the water metabolism, there are two ways it is being maintained. 2% increase in the extracellular fluid osmolality. That means the ECF is rather hyperosmolar by 2%. Then there are osmoreceptors in the CNS which are stimulated, and they go through the mechanism which we have seen earlier, ADH, antidiuresis, water conservation, and increase in the circulatory volume, and that brings down the increased ECF which has started here. Likewise, there is a decrease in the circulating volume. This is a osmolarity has increased or the volume has decreased. For the volume decrease because of dehydration or any reason, the circulating blood volume comes down, the baroreceptors are stimulated. These baroreceptors basically act on the angiotensin 2. This angiotensin 2 is a dipsinogen. It stimulates the center, the third center. Thirst is stimulated, water acquisition by oral route, and also angiotensin 2 is inhibited by the atrial natriuretic peptide once the circulating volume is restored. Also, baroreceptors act through the ADH to conserve water through the kidney by increasing the circulating volume. So there are two stimuli. One is an increase in the osmolarity, which acts on the osmoreceptors, or a decrease in the circulating volume, which activates the baroreceptors. Both end up in water conservation. Just the reverse happens. If there is a decrease in the osmolality here and here, and then if there is an increase in the volume due to heart failure or or cirrhosis or whatever it is, just the mechanisms are reversed, and then diuresis is promoted and water is excreted. In heart failure and then cirrhosis or other water retaining conditions, this mechanism is overwhelmed, so the body is not able to throw out water. Patient becomes edematous. Okay. This is the Bowman's capsule of the kidney. This is the urinary space. This is the capillary lumen. Blood comes here in the circulating in the capillary, and there are capillary endothelial cells here. In between there are holes. These are called the fenestra. In the basement membrane, of course, there is a basement membrane which has to be permeable. In diseases where basement membrane is involved, the movement of electrolytes and water through that will be a problem, and there are food processes on the urinary space side of the Bowman's capsule, and there are again openings there, and these openings also allow water and electrolytes to be filtered. Okay, now, so this transportation sites also we know we have the filtration here going on, and then there is a descending limb of the loop. This is the proximal convoluted tubule, and then the descending limb of the loop of Henle, the ascending limb of the loop of Henle, then the DCT, and then the collecting ducts. 80% of the water, 75% of the water absorption occurs right in the descending limb and the proximal convoluted tubule itself, and only a small proportion of water is available for regulation to fine-tune the amount of water that is excreted. And there are channels what are called the aquaporin channels, aquaporin 1, aquaporin 2, and aquaporin 4. Aquaporin 1 is not under the influence of ADH. So much so the PCT and the descending limb water movement is not controlled by the ADH. Other than that, the one that is there in the outer medullary region, the distal convoluted tubule, and the collecting ducts, the inner medulla, they are under the influence of the ADH, particularly through the aquaporin 2, and these facilitate the movement of water depending upon if the water is to be retained, the aquaporin channels will absorb more water, and then they are open and then allow the water to get into the interstitium. If the water has to be excreted, then the aquaporin channels are closed, so much so the water is excreted in the urinary space and more amount of urine is produced. Okay. Now, as I told you here, this part of the water reabsorption, here 290 milliosmoles, 180 liters, and 36 liters is the volume here by the time it comes. That means around 75%, 80% is reabsorbed by the time it is here. There are 26 liters, and by the time it is in the urine, 1.5 to 1 liter only is excreted. And the area that is marked here is under the influence of the aquaporin channels, aquaporin 3 and 4, which are under the control of the arginine vasopressin. What does arginine vasopressin do? It comes and attaches to the V2 receptor on the basolateral side and then stimulates the cyclic AMP. The cyclic AMP goes and opens these vesicles are there, the aquaporin 2 channels. They are opened up on this side and freely water enters. Whatever water that has entered, it will come out into the interstitium through aquaporin 3 and 4. So opening up of these channels is under the influence of the arginine vasopressin, which occurs in this part of the collecting tubule and the collecting ducts of the renal mechanism, renal tube. Okay. Now, so what is the amount of water that is filtered? Glomerular filtration rate 120 ml per minute into 60 minutes into 24 hours. Now, the amount of water that is filtered is 170 liters, but the amount of urine excreted is... Hello, please close your mics. Murali Krishna. Body, hello? Hello, please close your mic. Okay, so the glomerular filtration is 170 liters and final urine is only 1.5 to 2 liters, and 99% of the filtered water is reabsorbed, only 1% is finally excreted, 70% is reabsorbed in the PCT by the action of aquaporin 1, and the rest 29% by the aquaporin 2, 3 and 4. And resorption of water in the CT, of course, is ADH mediated. Okay. So we know there are two stimuli. One is the decrease in the volume, the other is increase in the osmolality. How they work, I have shown you in the previous chart. Now, what are the complex interacting things that handle the water balance? Osmolality, plasma volume, thirst center, kidney, posterior pituitary and the hypothalamus. Dysfunction in any one of these areas can result in hyponatremia, because immediately the water, supposing there is more water, immediately there will be a fall in the serum potassium, sodium. That is hyponatremia, because any one of these disorders can lead to that. So now, what are the clinical disorders which can be associated with water balance and indirectly with the sodium balance? Cardiac failure, cirrhosis, renal failure, hypothyroid, Addison's disease, central diabetes insipidus, which we have seen very extensively previously when we are dealing with the water metabolism, nephrogenic diabetes insipidus and psychogenic polydipsia. These are the three forms of diabetes insipidus which we have already understood earlier. Okay, now coming to basically after the water metabolism briefing, I am starting with the sodium. It is defined as serum sodium below 135. Hyponatremia by definition is 135. Below that, if it is there, then you call hyponatremia. Normally it is 130, 138, 137, 140 like that. Most common electrolyte disorder encountered in clinical practice occurring around 22 to 30% of hospitalized patients. That means what? We are not recognizing. We don't find that many in our clinical practice. Means in every hospitalized patient, we need to do the electrolytes, serum electrolytes, and that means we have to, then only we will be able to find out whether there is hyponatremia or not, because for it to be symptomatic, it will take time. Okay, so for it to be symptomatic, it may require time. So that is why we need to understand the importance of doing electrolytes in all the patients. Okay, so 135, remember, as the point where we require to think that it is hyponatremia, and it is of two types, acute or chronic. Acute and chronic. Acute is 50% of the cases are acute, and 10 to 20% of the patients it may be chronic, occurring in around 20 to 30% of hospitalized patients. And most challenging to the physician, what is the cause of the hyponatremia? We do not know. We have to basically evaluate it. Basically, hyponatremia is not related directly to the sodium. It is a disturbance of the water. That one has to understand. So what is the clinical importance? Acute severe hyponatremia can cause substantial morbidity and mortality, and adverse outcomes are higher in hyponatremia in patients with a wide range of underlying disorders. Okay, overly rapid correction of chronic hyponatremia can cause neurological defects, central pontine myelinolysis and other things. So three important things: it's a substantial cause of morbidity and mortality. Number two, the underlying disorders have to be looked into which could lead to hyponatremia. Number three, too vigorous and too heroic correction might end up in neurological disability. So plasma sodium concentration less than 135, concentration of CCF sodium is a reflection of the tonicity of the body fluids. Why? Because sodium is the dominant one which is telling about the tonicity. Okay, it doesn't tell about the total content, but it only tells how tonic is it osmotonic or hyperosmolar or normoosmolar. That only it will tell. Hyponatremia can be associated with all the three tonicities. This is the big issue here. Hyponatremia does not mean hypotonicity alone. Hyponatremia can be hypotonicity, normotonicity or hypertonicity. Now we have to look at that. There is what is called Pseudo-hyponatremia. This, first of all, we will understand this and put it aside. This is called pseudo-hyponatremia because it is associated with normal or increased tonicity. So there is hyponatremia, but look at the plasma osmolality, it is normal or increased. Expands to the extracellular fluid with isotonic fluids that do not contain sodium. So what did we do? We have infused some fluid which is not containing sodium, so much so the plasma osmolality is normal or increased, but the sodium is lower because excess fluid is infused, otherwise known as a dilutional hyponatremia. There is no transcellular shift of water, but the sodium decreases because we have infused non-sodium containing tonic solutions. Example, hypertriglyceridemia can produce pseudo-hyponatremia because these triglycerides will increase the tonicity and that increases the volume inside the vessel, and thereby there is a dilution, there is a hyponatremia which is pseudo. Likewise, hyperproteinemia, as in case of multiple myeloma, can also produce. Raise in the plasma lipids of 4.6 grams per liter or plasma protein increase, as in multiple myeloma, can cause pseudo-hyponatremia. Concentrations greater than 10 grams per deciliter will decrease the sodium concentration by 1 milliequivalent. So concentration of the plasma lipids, if it is more than 10 milligrams, it will affect the plasma sodium. So hypertonic hyponatremia. So the first is pseudo-hyponatremia, then is called the hypertonic hyponatremia. Means there is hyponatremia we see less than 135, but then the tonicity of the plasma is higher. Seen when there is an increase in the effective osmoles in the extracellular fluid, shift of water from the cells to the ECF, and thus causing translocational hyponatremia. That means that there are effective osmoles are there in the extracellular fluid, and there is a shift of water from the ECF into the vessel, and that produces what is called translocational. The fluid is translocated and then produces hyponatremia. But the tonicity, if you look at it, is hypertonic. Hyperglycemia is an example of that, where plasma sodium falls by 2 milliequivalents per liter, because there is we know in the formula there is glucose divided by 18 is there. So that if the glucose is more, naturally for every 100 milligrams per deciliter increase in the glucose between 200 to 400, the fall is by 2 milliequivalents. It's 4 milliequivalents if the glucose is more than 400. So also hypertonic mannitol also can produce this. So these are two which are solute overload. The solute like mannitol or the glucose is overloaded in the system, so much so there is a consequent fall in the osmolality, because relatively these contribute for the osmolality, and the osmotic molecules will draw more water and there will be hyponatremia. So this is called, but if you look at the tonicity is higher. Why? Because the glucose or the mannitol or some tonic substance is contributing for the hypertonicity. The hyponatremia is translocational. So this is one category which we need to differentiate. Then the otherwise known as the second one is the hypotonic hyponatremia, where the plasma tonicity is lower as expected in dehydration. There is hyponatremia, there is also hypotonicity. So for example, there is dehydration due to diarrhea and vomiting. There is hypotonia and also hypotonic, and then hypotonic and also the hyponatremic. Hypotonic hyponatremia is the most commonest form. Hypotonic hyponatremia occurs by two mechanisms: impaired renal water excretion or excess water intake. So here what happens is water excretion is at fault, then not much of water is thrown out, water is retained, so sodium appears to be lower, or somebody is compulsively drinking more water, that can also produce hypotonic hyponatremia. Hypotonic hyponatremia is again of three types. Okay, hypovolemic, euvolemic and hypervolemic. Now you see how many we have. So we have pseudo-hyponatremia, which is a different entity. We have set it aside. After that, we have hypertonic hyponatremia, hypotonic hyponatremia, and normotonic hyponatremia. Third one. Well, among the hypotonic hyponatremia, then immediately you have to look at the volume. Is it hypovolemic? Is it euvolemic or hypervolemic? Clinically also this can be assessed by jugulars, heart rate, edema, blood pressure and all that. Depending on that, we have to decide whether it is hypovolemic or euvolemic or hypervolemic. The causes are different. Skin distance, skin turgor, mucous membrane dryness, venous distension, jugulars, edema, heart rate, blood pressure, all these are summarily they will give you an assessment of the volume status of the body. So whenever we see a case of hyponatremia, first of all it should run in our mind, am I dealing with hypotonic hyponatremia or hypertonic hyponatremia or normotonic hyponatremia? How do I resolve it? Immediately look at the plasma osmolality. If the osmolality is low and there is hyponatremia, you are dealing with the commonest form of hyponatremia, which is hypotonic hyponatremia. Then is it hypovolemic, is it euvolemic, or is it hypervolemic? Easily now you can say hypervolemic, a patient of cirrhosis of liver, a patient of congestive heart failure or nephrotic syndrome. Hypervolemic, dilutional hyponatremia. A patient of hypovolemic, patient of dehydration, patient of diarrhea, vomiting, of any reason, or patient who has gone into the hot sun, so he loses sweat, he loses sodium, he loses water, and there is hypovolemia. Okay, so the causes will come later, but remember that hypotonic hyponatremia is a common form, and immediately look for the clinical signs of volume status along with the osmolality. So once it is hypotonic hyponatremia, what is my clinical volume status? Hypovolemic, euvolemic, and hypervolemic. Now this is the way of looking at it very clearly. Carefully understand this chart. So as we said earlier, hypotonic hyponatremia is the commonest form, and that we are now going to deal with that. Okay, assessment of volume status. All of you know how to assess the volume status. Then the blood pressure, the pulse rate and the volume of the pulse, JVP, edema, water retention signs, ascites, and then the venous distension, mucous membranes, and underlying etiology all will point to whether you are dealing with hypervolemia or euvolemia or hypovolemia. So fundamentally classify the patient into hypovolemia, euvolemia, and hypervolemia. What is happening in hypervolemia? There is retention of sodium and water, but water is more retained compared to sodium. That is why there is relative hyponatremia. So water is more withheld compared to the sodium. There is water retention, sodium retention also is there, but water is more retained. That is why it is hypervolemia. And there is hyponatremia there. Okay. In that case, what will happen here? Then there is, you look at the urine sodium. What is the urine sodium like? Urine sodium more than 20, that means it is acute or chronic renal failure. ANI, that is the acute kidney injury, aka acute kidney injury, or it could be CKD. Okay. If the urine volume is, sodium is less, that means sodium is not normally excreted, there is nephrotic syndrome, cirrhosis, cardiac failure, sodium is retained, that's why we are not getting enough sodium in the urine. So, very easy, if you know that it is a hyponatremia, look for the tonicity in the plasma. It is hypotonic hyponatremia. Then what is the volume status? The volume status is high. Then look for the urine sodium. Urine sodium is low, sodium is not being excreted, sodium is retained, conditions like cardiac failure, cirrhosis, nephrotic syndrome. But urine sodium excretion is more than 20, that means selectively water is more held up rather than sodium. That is why you have chronic or acute renal failure due to AKI or CKD. Then come to this side, hypovolemia. There is total body water is lower, it's lost, but sodium is lost more than water. That is why you see hyponatremia. So loss of water and sodium is more lost compared to water. That is called hypovolemic hypovolemic hypotonic hyponatremia. Three qualifications: hypovolemia, hypotonicity, and hyponatremia. Okay. Now again, urine sodium will be a guide for you. Suppose urine sodium is more, that means sodium wasting is there in the kidney, renal loss, or you are using diuretic, or there is a mineralocorticoid deficiency, mineralocorticoids retain sodium. In the absence of mineralocorticoids, body is not able to retain sodium, so urine sodium is more, or salt losing situations and bicarbonate deficiency, bicarbonate with renal tubular acidosis, or metabolic alkalosis, ketonuria, osmotic diuresis, cerebral salt wasting syndrome. These are all the various causes, out of which most common things are diuretic use, renal losses of sodium, mineralocorticoid deficiency, and then renal tubular acidosis. Osmotic diuresis are some of the common causes of hypovolemic hypotonic hyponatremia due to excess loss of sodium through the kidney, or sodium not being conserved at the kidney. The other way around, in presence of hyponatremia, we expect the kidney not to lose sodium. We expect the kidney to withhold sodium excretion. If that is reflected by low urinary sodium, means the sodium is lost from other than the kidney. And this is all renal losses. These are all extra renal losses. Vomiting, diarrhea, third space sequestration, burns, pancreatitis, trauma. That is somehow or other, the sodium is lost from the body in a different mechanism other than the kidney. Okay, now we are left with euvolemic hypotonic hyponatremia. Euvolemia means there is neither edema nor dehydration. There are no signs of dehydration. There are no signs of excess water or fluid overload. That means total body water is just increased. Total body sodium is unaltered. Just there is an increase in the body water. That has produced a little dilutional hyponatremia. Body sodium is being normal. The osmolality is maintained, because we know the osmolality is dependent upon sodium, glucose, and blood. So sodium being normal, the osmolality is not very much lower, but not very much higher or anything. In spite of there being any excess body water, we don't expect there is no increase in the fluid overload in such situations. And here again, the urine sodium comes into picture. Urine sodium is more. That means glucocorticoid deficiency, hypothyroidism, stress, certain drugs, syndrome of SIAD. This is what that means. The water is being retained not because of the ADH secreted from the pituitary, but the ectopic ADH is secreted from some other source, which is retaining the water. And normally, what should retain water? ADH has to retain. So if the ADH retention of water occurs, then there is excess ADH from the pituitary. But then, in this condition, the ADH is not from the pituitary, it is from outside the pituitary, ectopic secretion or inappropriate secretion. Inappropriate here because there is excess body fluid, water is there, but then there is antidiuretic hormone should not be secreted, it should be stopped, it's not suppressed. That is called inappropriate secretion. Inappropriately high levels of ADH-like molecule which acts like ADH, though it is not from the posterior pituitary. That is the cause. Okay. If you understand this, 50-60% of hyponatremia you have understood. So fundamentally, when a patient comes, the question is, does he have hyponatremia? Look at the serum sodium. Serum sodium less than 135. is starting of hyponatremia, anything less than 130 or 125, it will be symptomatic hyponatremia. There is a way of looking at symptomatic way also. I'll show you in the later slides. The first question is there hyponatremia? Second question is what is the tonicity of the blood? Is it hypertonic? Is it hypotonic? Is it normotonic plasma? Okay, if it is hypotonic hyponatremia, then I may end up with three reasons. 1. Hypovolemia. 2. Euvolemia. 3. Hypervolemia. I have already told you how to assess the volume status. And then if it is hypervolemia, then I am retaining more water than sodium. That is, the volume is there and relatively I am seeing hyponatremia. That is because more water is there, there is called dilution also is there. And how do I decipher? Then look at the urine sodium. If the urine sodium excretion is less than 20%, 20 milliequivalents, that means there is nephrotic syndrome, cirrhosis or cardiac failure, wherein the sodium and water both are retained, but then water retention is much more than the sodium retention. Whereas if the urine sodium is more than 20, then acute or chronic renal failure is the answer. So go to the left hand side. Hypovolemic Hypotonic Hyponatremia. Here total body water is decreased, but sodium is further lost. Relative to the water, sodium loss is more. Is it renal or extrarenal? How do I know? If I look at the urine sodium, if it is renal, the urine sodium excretion will be higher, as in case of diuretic use or mineralocorticoid deficiency. Sodium is not being conserved, salt losing conditions of the kidney, bicarbonaturia with renal tubular acidosis and metabolic alkalosis, ketonuria, osmotic diuresis, cerebral salt wasting syndrome. In all these conditions, there is loss of sodium more from the kidney compared to the water loss. That is why there is hypotonia, hyponatremia. Okay. Now, what if it is not kidney, where from it can be lost? Maybe if the urine sodium excretion is rather reduced as expected in a case of hyponatremia, that means a lot is loss is occurring somewhere outside the kidney, means vomiting, diarrhea, third space fluids like in a pleural space or ascitic fluid or peritoneal space, or pancreatitis, burns, trauma. And we are now left with euvolemic hyponatremia. Hypotonic hyponatremia means total body water has increased as well. There is increase in the total body water, but sodium is normal. Then again look at the urine sodium. The urine sodium is more. Then it could be glucocorticoid deficiency or hypothyroidism or stress or drugs or syndrome of inappropriate. Most important thing is syndrome of inappropriate hormone. Suppose the urine sodium is normal, less than 20, then that means there is a compulsive water drinking. The person is drinking more water because of compulsive water drinking. Okay. Now, so we go about now hypovolemic hyponatremia. Both sodium, water is decreased and sodium is more decreased. Gastrointestinal third space losses, step by step. Vomiting or diarrhea, history of vomiting or diarrhea, or there is burns, or there is peritonitis, or there is bowel lumen ileus is there, that means fluid is sequestrated in the bowel lumen. These are two. Burns and peritonitis are two conditions. Burns is separate with this one. So vomiting and diarrhea. Next one is loss of water, loss of sodium, loss of chloride, free water or hypotonic fluid intake. So somebody is the easiest way is somebody is going in the hot sun or taking a marathon and he feels thirsty, he drinks water, he doesn't drink salted drink, he just takes plain water. What will happen? The sodium will be lower, hypotonic fluid intake, or water is taking more and not taking the salt replacement. If you want to avoid heat-related disorders, whenever we feel thirsty, not just drink water at least 3 or 4 times. We have to drink fluids containing salt also. Then vasopressin due to volume contraction, hypovolemic hyponatremia. So there is a vasopressin activity is there, and hypovolemia as well as hyponatremia or excess vasopressin. Vasopressin is suppressed. Then there is diuresis and hypovolemia and hyponatremia. So salt-losing nephropathies, what are the conditions of salt-losing nephropathies? Sodium increase, decrease due to impaired renal tubular function, reflux nephropathy, interstitial nephropathies, post-obstructive uropathy, medullary cystic disease of the kidney, recovery phase of acute tubular injury. All these are causes of salt loss. Excess diuretics, particularly thiazide and loop diuretics, they lose sodium, whereas the other types of diuretics we use. So here particularly the culprit diuretics is the thiazide diuretic you use more, or the loop diuretics we lose sodium, blunting the countercurrent mechanisms. So there is water diuresis in excess of natriuresis. Now, osmotic diuresis. What is this? Excretion of osmotically active, non-reabsorbable, poorly reabsorbable, like glycosuria or ketonuria, either in starvation diabetes or alcoholic ketoacidosis or bicarbonaturia. In all these conditions, there is a sort of osmotically active, non-reabsorbable substances are there. So with the result, you lose water and sodium through the kidney. Cerebral salt wasting syndrome. What is this? A rare cause of hypovolemic hyponatremia. We don't have to really know much about these things. Hyponatremia is there. There is clinical hypovolemia. There is inappropriate natriuresis. That means the urine sodium is much higher in the presence of hyponatremia. When there is hyponatremia, we don't expect the kidney to lose sodium. But here there is natriuresis. Why? Intracranial disease like subarachnoid hemorrhage, trauma, craniotomy, encephalitis, meningitis. These can produce cerebral salt wasting syndrome. Release of B-natriuretic peptide is the cerebral dysfunction. Differential diagnosis is SIAD. Because SIAD, there will be inappropriate antidiuresis because the SIAD, the antidiuretic hormone is not from the posterior pituitary, but from somewhere else. Cerebral salt wasting typically responds to aggressive sodium and chloride repletion. Now, how do I go about examining the patient? So, physical examination, I have to look at the wasting, cachexia, in case of malignancy, diabetes insipidus and diabetes mellitus, skin manifestations in cases of cancers and diabetes mellitus, nail changes in chronic diseases, clubbing, CKD nails, carcinoma bronchus. Anemia again is a feature of CKD and malignancy. Lymphadenopathy, infiltrate and malignancy disorders. Fundus examination for hypertension, diabetes and papilledema. So these are some of the physical examinations apart from assessing the volume status. Okay, remember wasting and cachexia, and then skin manifestations, nail changes, anemia, adenopathy, fundus examination, and of course your volume status measurements are very essential part. So conditions with urine sodium less than 20. So that is what urine sodium is the guide for more non-renal causes of hypovolemic hyponatremia. That means urine sodium excretion is conserved. And that means there is somewhere else we are losing the sodium, gastrointestinal diarrhea, or tube drainages, and then third space fluids like pancreatitis, burns, and a rapid increase in the sodium concentration in response to intravenous normal saline, and saline induces water diuresis in this setting as a result of circulating AVP levels. Then we are now with the euvolemic hyponatremia. So first we went through the hypovolemic hyponatremia, then we went to the hypovolemic hyponatremia. We had causes like the different causes, the gastrointestinal causes and the renal causes. In the renal causes we had cerebral salt wasting, osmotic diuresis, salt losing nephropathies, and hypovolemic hyponatremia. These ones. Now when you come to the euvolemic hyponatremia with normal ECF volume is definitely, mostly it is SIAD, syndrome of inappropriate antidiuretic. So if you find a patient with hyponatremia and the volume status is normal and and then the cause could be SIADH. So there could be also other reasons like hypothyroidism and adrenal insufficiency also should be thought of. So we'll need to know a little bit about SIAD. SIAD is a more accurate term, syndrome of inappropriate antidiuresis. So SIAD, ADH is inappropriately elevated in SIAD. That means normally whenever we have hypovolemia, hyponatremia, the pituitary will try to sort of conserve water. But in some cases where the pituitary's secretion of ADH is not affected or normal, but the ADH is coming from some extraneous source, that is the one which is retaining water. So mechanisms enhanced and unregulated ADH secretion by a tumor or from the hypothalamus. Elevated secretion of ADH in the basal state in response to hypertonicity or the osmostat is reset. That also is called the reset osmostat because of cerebrovascular disease. Activating mutations of the V2 receptors permitting reabsorption of water in the absence of ADH. Normally without ADH there should not be reabsorption of water because V2 receptor requires ADH. When there is a mutation of the receptor, even in the absence of ADH, there will be water reabsorption will be there. Natriuresis in the presence of water retention leads to inappropriately concentrated urine or increase in the ANP, that is atrial natriuretic peptide. So SIAD could be a short note for you, and there will be other manifestations associated with that. This is a separate topic we can discuss separately. Diagnosis, how do I diagnose? There will be serum sodium will be lower, plasma osmolality is 285 normal, it is slightly lower, urine osmolality is more, and urine sodium concentration is more, and patient clinically euvolemic in the absence of clinical or biochemical features of adrenal or thyroid function, because similar picture can be caused by adrenal or thyroid function. The similar picture can be due to hypothyroidism or hypoadrenalism. So in the absence of hypothyroidism or hypoadrenalism, if you have low sodium, if you have euvolemia, and then if urine osmolality is more than 100 milliosmoles, and then urine sodium concentration is more than 20 milliequivalents, then the patient is euvolemic in the absence of biochemical features of adrenal thyroid dysfunction. We have to consider syndrome of inappropriate secretion. There are other endocrine disorders which can result hypothyroidism and adrenal insufficiency, euvolemic hyponatremic, euvolemic hyponatremia, hyponatremia in euvolemia. Other causes are endocrine disorders which we have listed there, and that also we have to keep in mind. Then we go to hypervolemic hyponatremia. Hypervolemic hyponatremia, causative disorders can be separated by the effect on urine sodium concentration. Is the urine sodium concentration more than 20 or is it less than 20? If it is more than 20, is it ARF or acute kidney injury or CRF or CKD? Okay, if the urine sodium concentration is less than 20, that means, there is retention of sodium as well as water due to congestive heart failure, nephrotic syndrome or hepatic cirrhosis, or low intra-arterial filling, movement of water from the vascular to the interstitial space. Suppose there is a hypoalbuminemia, there is no osmolality in the plasma, so water tries to move from one compartment, from the vascular compartment to the interstitial compartment, and activation of neurohormonal compensation can also occur. This is what is called hypervolemic hyponatremia. Now, exercise-induced hyponatremia. Marathon runners, females with low body weight, excessive drinking of hypotonic solutions. As I told you, in a hot summer, one worker is working, he's sweating, and he's just replenishing only water and not taking salt, then it can lead to hyponatremia. Inappropriate secretion of ADH due to muscle-derived interleukin. Sometimes when there is a marathons runners, what will happen? The muscle being fatigued, it secretes interleukin 6, and that inappropriately secretes ADH. In case of marathon runners, there will be sort of relative muscular injury due to relative ischemia due to excessive exercise that can cause IL-6 from the muscle, which can activate ADH and produce this hyponatremia, exercise-induced hyponatremia. The common reason, of course, is replenishing with hypotonic solutions when we have to take salted drinks. So, clinical diagnosis, the symptoms primarily neurologic development of cerebral edema with rigid skull, headache, lethargy, confusion, gait disorder, nausea and vomiting, severe hyponatremia. So mainly what are the symptoms of hyponatremia? Neurological symptoms. Neurological symptoms, then there will be nausea and vomiting, and there will be hyponatremia, seizures can occur, coma, brainstem herniation, permanent brain damage and death. So what are the levels of hyponatremia? Less than 135, mild, less than 130, moderate, less than 120, life-threatening and severe. These are the clinical. Remember, hyponatremia, majority of the symptoms are neurological. Patient comes with lethargy, confusion, headache, gait disorder. Anybody who is confused, lethargic, severe headache, first check the electrolytes. And it could be hyponatremia, life-threatening hyponatremia, which requires immediate treatment. And if we delay, seizures, coma, brainstem herniation, permanent damage to the brain and death can occur. It is classified as less than 135, less than 130, less than 120 being the severe. Severe hyponatremia, less than 120, rapid development of hyponatremia. And the severity is not only in the level, but also in the rapidity of development. If the hyponatremia develops rapidly, body cannot tolerate hyponatremia to great extent. But at the same level of sodium, if it occurs over a period of 1 month, slowly, then there is echematization, a key complication of normocapnic or hypercapnic respiratory failure. Hypercapnic respiratory failure, there will be more carbon dioxide retention, respiratory failure, and there will be associated severe hyponatremia. Normocapnic respiratory failure is non-cardiogenic, neurogenic pulmonary edema, or with a normal pulmonary capillary bed pressure. Unlike the cardiogenic failure, where that is not hypercapnic respiratory failure, and there is a pulmonary edema and capillary wedge pressure has increased. You see the volume overload. Persistent chronic hyponatremia, unlike the previous one where we have seen severe acute hyponatremia, here persistent chronic hyponatremia, efflux of organic osmolytes like creatinine or glutamate or inositol or taurine from the brain cells. That because during chronic persistent hyponatremia, these osmolytes come out of the brain cells, and then there is an increase in the intracellular osmolality and greater than the water entry. So complete within 48 hours time period defines chronic hyponatremia, vomiting, nausea, confusion, seizures, same symptoms like the other one, gait changes, cognitive defects, increased risk of falling and risk of bony fractures. This is a persistent chronic hyponatremia. If it is there, then it will be, slowly it happens, then it becomes chronic hyponatremia, and then the symptoms are more or less the same. So how do I diagnostic evaluation of a patient of hyponatremia? I don't know what is the present time. We started at 11:40. This is 12:40, 1 hour. And how many slides I have? Let me check that. Yeah, we have another 20 slides. Maybe we will go from here in an algorithmic manner where you will be seeing very easily how to go. The workup will be there, what test, additional test, and then use the algorithms to decipher each and one particular condition. And then these are the various ways you have to certainly understand those things. Maybe I stop at this point just to give you a background and the summary of that. Hyponatremia is a very common clinical condition. Second thing is hyponatremia is symptomatic neurological symptoms occur. Hyponatremia may be underlying cause for majority of the deaths that we see. We have to evaluate every admitted patient for electrolytes. And what do? First thing I do is serum electrolytes. If there is a shift in the sodium below 135 or 130, immediately look at the osmolality. Then I know whether I am dealing with hypoosmolol or normoosmolol or hyperosmolol. In other words, it is called hypotonic, normotonic, hypertonic. The commonest is the hypotonic type is common. In the hypotonic, I have hypovolemic, euvolemic, and hypervolemic. The causes are different, and we know how to separate them using the urinary sodium. Also, syndrome of inappropriate antidiuretic hormone, endocrine disorders, chronic renal disorders, salt wasting disorders, water and salt retaining disorders in the hypervolemic type, all have to be kept in mind. Now I'll show you from next class, I'll show you how you go step by step, algorithmically, and then arrive at the exact diagnosis. Once we know that, then we know what fluid to replace. Generally, hyponatremians don't immediately start on 3% sodium chloride, which is not correct. You may endanger the patient. Suddenly, particularly central pontine myelinolysis can occur. These are some of the risk factors for the central pontine myelinolysis. And so this is how we will go about. Maybe we'll continue next Tuesday about the algorithmic approach, and maybe we will finish hypernatremia also along with hyponatremia in that class. Algorithmic diagnosis and treatment of hyponatremia, and then hypernatremia will be the part of next class. Today what we did, looked at the water balance, looked at the profile of hyponatremia. What are the various types? It's not one disorder. And we also looked at the pseudo-hyponatremia, the fictitious hyponatremia that we have seen. All these conditions are very clinically looking very similar, but one has to be very careful in separating them, for which we use the algorithm as well as the treatment algorithm. With that, I stop sharing.